I hope and wish all of you a happy new year and كل عام وانتم بخير. The topic today I'm going to talk about is liver resection for metastatic colorectal cancer in the era of targeted therapy. And the question I'm going to try to answer is, can the inoperable become operable? I presented a similar talk in the Jordan Oncology Society meeting, and unfortunately it was not well attended. So I thought it's reasonable to present it to this elite group of people who are really interested in this kind of topic and basically literature. This is the outline of my lecture. That the bulk will be on the main topic, which is the liver resection in the era of targeted therapy. What's the evidence? And then I'll provide a quick summary on our experience at KHCC for liver resection for the last 2 years. And then provide you some updates on the Stop CLAPSY project that I had the honor to lead over the last 2 years at KHCC. As you all know, in the States, colorectal cancer is the third most common frequently diagnosed cancer, second leading cause of cancer-related death. Up to a third of these patients presents with metastasis, and 50% will develop metastasis down the road after their primary resection. In Jordan, it is the second most common frequently diagnosed cancer after breast. It is, as we all know, the most common in men and the second most common in women. And in terms of presentation, this is from 2009 data. The 2010, the Jordan Cancer Register did not present these data, but up to a third of them presents with metastasis. So similar to the United States, 21% in colon and 9% or 10% in rectal presents with metastasis. So the natural history of patients with colorectal liver metastasis untreated usually is very poor. We have a median survival typically less than 12 months and no 5-year survival. These are untreated patients. And this is the early view by Dr. Ogilvy that a lot of you know. He's a famous British surgeon. This is his view back in 1953, where he stated partial hepatectomy for malignant disease can very rarely be justified. Secondary metastases are nearly always multiple, and it can be assumed that many seeds of cancer, still impalpable, are scattered throughout the liver. Although some of these theories are still held true up to our age, but a lot of people will disagree with this view by Sir Ogilvy. This is Dr. Wagner back in '84 presented his data, and he showed that for solitary resected colorectal liver metastasis, they do the best. Even multiple resected, they also do very well compared to unresected colorectal liver metastasis. And if we look at what we have in terms of survival for different modalities, for best supportive care, they do very poor. 5-view add little to the best supportive care. Modern chemotherapy, where we can now see 5-year survival even with modern chemotherapy without surgery, but again, nothing compared to surgical resection, where we're now talking about 30%, 10-year survival. We're not talking about 5-year survival anymore. So this significant improvement over the last 2 decades, I believe it's due to multiple factors. It's the patient selection, where we are better at patient selection. We are better surgeons, at least we have better surgical techniques, and we have better systemic chemotherapy. Unfortunately, only 20% of patients presented with resectable disease, and the question is, can we increase the percentage of patients with resectable colorectal liver metastasis? And this is mainly to achieve an R0 resection to get them into, hopefully, the 10-year survival group. And as you know, we have 2 main modalities. We have surgery and we have chemotherapy. As I can tell you that we surgeons will become more aggressive. We have better understanding of the liver physiology, anatomy, and pathophysiology of the disease. We have a new definition of resectability that I'm going to talk about. We have adjunct for surgery that helps us also increase the pool of patients who become resectable, like portal vein embolization, the 2-stage hepatectomy approach, resection combined with ablations. All these had increased the chance of patients to become resectable. And on the other hand, chemotherapy, it's either systemic, which is going to be the topic of my lecture today, and then the regional chemotherapy that Dr. Amr Zriqat from Pittsburgh had described his experience here a couple of months ago. This is the old definitions of resectability for colorectal liver metastasis. It was determined by the number, the size, the presence of bilobar disease, and the presence of extrahepatic disease. From all these criteria that was held, was very strongly applied back in the 1990s, none of them held true anymore. and the new definition of resectability had evolved until a consensus guidelines back in 2006 from NCCN and SSO, where they classify resectable based on the ability to preserve two continuous hepatic segments with adequate inflow, outflow, and adequate future liver remnant. So basically what you need, for example, is just segment 2 and 3 with an outflow and inflow with biliary drainage, an adequate future liver remnant that's defined 20% in normal liver, 30% post-chemotherapy, and 40% of patients with cirrhosis. This new definition had created a lot of dilemma in the surgical field. As you see before, the definition was clear. It's a number, size, extrahepatic disease, unresectable. So what's clearly defined and easily defined. But the problem with this evolving new definition, it depends on a lot of surgeons' experience and variability, and it's more difficult to define nowadays. And this has been clearly shown in this nice study from Canada, where they surveyed 46 hepatic surgeons across Canada about similar different case scenarios with CT scans, and they found they agreed in 4 out of 8 scenarios. So there will be significant lack of agreement among surgeons on whether this is resectable or unresectable. And this new problems, I think it's just part of the dynamic literature where new definitions come. We have to really modify them and justify and work on them more to be more precise. Is it all about surgery? Definitely not. It's the multidisciplinary management that had evolved and shown in multiple studies that it's really what matters for this group of patients. We were better as surgeons in terms of surgical techniques and instruments and machines, and also chemotherapy got much better. We have the systemic chemotherapy, we have the targeted, the anti-VEGF and anti-EGFR that can be used only in patients with wild-type KRAS. There's a new multi-other drugs on the horizon for patients with this disease. This is a very nice study from MD Anderson that I keep showing in my talks because I think it shows just the summary of what I've been talking about. The improved outcome, it's because of both the adoption of more aggressive approach of hepatic resection as well as the improved chemotherapy. So they will become more aggressive in MD Anderson doing liver surgery in the late 1990s, early 2000s. And you can see the 5-year survival in their registry had improved significantly. Similar thing, they were more aggressive adopting modern systemic chemotherapy back in 2004, and this has resulted in also an improved survival. So it's both surgery and chemotherapy and the multidisciplinary management. In general, we can classify patients with colorectal liver metastasis. We have clearly upfront resectable disease. We have patients with borderline resectable that I think this is where most surgeons would disagree or have less lack of agreement. Then we have clearly unresectable disease. What I believe myself, that these diseases are not equal. What I believe is the biology of patients with clearly resectable definitely different than a patient with borderline resectable and patients with unresectable. Unfortunately, we still have the one-fits-all criteria. We are working on defining more biomarkers to really classify these patients in a better way. But this is, again, we still depends on CT scan and TNM staging to classify patients rather than really the biology and biomarkers of these patients. In general, patients with resectable disease can go either for surgery or chemotherapy. Patients with borderline resectable, once you say that word, borderline resectable, typically they go for chemotherapy. Nobody would take patients with borderline resectable to surgery, and then patients with unresectable, they will go with palliative chemotherapy. Just look at this term, conversion and downsizing. That term has been in the literature only for 2 years, not anymore. And I think it's very interesting to see what's evolving in the literature with this term. It's being more used and more utilized. So the goal for patients with resectable or borderline resectable is always to go for an R0 resection. And the question is also, can we get this group of patients, especially with liver-only disease, to this R0 resection? I think this is something we are working on, and I'll provide some data that this might be happening soon. Chemotherapy comes with a cost. There's a problem with chemotherapy, and we're all aware of chemotherapy-induced liver injury. You have two main patterns, steatohepatitis and the sinusoidal obstruction syndrome, or called the blue liver syndrome. What we know about chemotherapy-induced liver injury is that irinotecan-induced steatohepatitis, it's an independent risk factor for postoperative mortality. And this is from MD Anderson data, and this is where most surgeons really afraid of when you use irinotecan and you operate on a patient. This is something you have to take seriously. What we know about oxaliplatin-mediated sinusoidal obstruction syndrome, it's an independent factor for postoperative complication, mainly bleeding and prolonged hospital stay. What we also know that more than 6 months significantly increase the risk of complication, and the addition of anti-VEGF, bevacizumab, reduces the incidence of oxaliplatin-induced SOS with no effect on liver regeneration of a questionable clinical significance. Nobody had proven that this could be beneficial or not. Another problem of chemotherapy that we at the GIMDC encounter every while and then is the disappearing liver metastasis. And it is, again, an evolving part of the literature. There's so many questions and little answer up until this point. In patients with resectable colorectal liver metastasis, as we said, it is controversial. Some people would go with surgery and some people would go with chemotherapy. But the question is, what is the best regimen? And the best answer we can find in the literature is from this level 1 evidence trial, the EORTC 40983, that most of you are aware of, where patients with resectable, again, colorectal liver metastasis, they're randomized to FOLFOX surgery, FOLFOX versus surgery alone, and basically the primary endpoint of the results, which is 3-year progression-free survival, was significantly better in the chemotherapy group compared to surgery alone. This is their most updated reports from 2013 with an 8.5 years follow-up. No difference in the 5-year survival, but again, the 3-year progression-free survival was significantly better. Again, they still use the progression-free survival as an endpoint in this patient. So in resectable colorectal liver metastasis, we know from level 1 evidence that FOLFOX works very well. Is it really justified to add the extra cost of targeted therapy in patients with resectable disease? Unfortunately, the evidence is not great out there, but we have this phase 2 trial where they add bevacizumab to K-box, capecitabine, oxaliplatin, and leucovorin. And basically, again, they are resectable patients with poor biology based on these criteria: synchronous disease, short disease-free interval, lymph node positive primary. So they are resectable, but according to the Fung score that was utilized back in the 1990s, they have poor biology. What they found that we have a very high response rate. Again, only 41 patients. 95% of patients underwent R0 liver resection. Again, most of these patients, again, all of them were resectable from the get-go. There were no increase in complications, no mortality, and 20% morbidity. So it's more of a feasibility trial that they concluded it is safe to add bevacizumab, but again, with no strong evidence to support its use based on its cost. This trial used, it's called the New Epoch trial. This is a very interesting, that had generated a lot of discussions in the literature over the last 6 months. It was published May of last year. It's called the New Epoch. They used added chemotherapy, cetuximab to FOLFOX or FOLFIRI in patients with wild type resectable. This is most of these patients were upfront resectable, and that's very important to notice this trial. It's only for resectable, and then they added the term or suboptimally resectable, and they define suboptimally resectable. It is potentially compromised margin, but again, they have to be treated with a curative intent. So this is, again, addition of anti-EGFR to chemotherapy in patients with resectable colorectal liver metastasis. And as you see, the primary endpoint was progression-free survival, was not conversion. They were not hoping to convert. These patients were resectable from the get-go. Most of these patients received oxaliplatin-based chemotherapy. Similar patient characteristic among the two groups between the chemotherapy and the chemotherapy plus cetuximab, again in wild-type KRAS patients. What was really surprising is that the response rate was slightly higher in the chemotherapy cetuximab group, but was not statistically significant between the two groups. So basically similar response rate, And also the R0 resection rate was high in both groups because both were resectable patients, and it was around 93% and 87%. Similar, no difference in the response rate, no difference in the resection rate, and for the primary endpoint, what they found that progression-free survival was shorter in patients with chemotherapy plus cetuximab. So in patients with resectable colorectal metastases, wild-type KRAS, the new EPIC trial tells us addition of cetuximab results in a worse progression-free survival as well as overall survival. This was a big surprise. I really congratulate the authors that they had the courage to publish this data despite its being pharmaceutically supported as well as a negative trial. And they try to find if there's any reason for that. So they did subgroup analysis, trying to find if the chemotherapy plus cetuximab had worse biology or worse disease characteristic. And unfortunately, they found the opposite, that the adverse effect of cetuximab was associated with characteristics normally deemed to be good prognostic features. So higher CA level in the chemotherapy group, more node positive primary in the chemotherapy group. So again, this was a big surprise for the patient, for people who are interested in this topic, and generated a lot of discussion. Their conclusion was the addition of cetuximab to chemotherapy and surgery for operable colorectal liver metastasis in wild-type KRAS results in a shorter progression-free survival, and at present time, use of cetuximab in this setting cannot be recommended. Northern J had wrote a very nice long commentary on this topic, where he tried to criticize the study on multiple levels, and he reached the point that when studies such as this ends up with a conclusion that is contradictory of similar trials in advanced colorectal cancer, we believe that confirmatory clinical trials are needed before clinicians should act on these findings. But what I think most people are missing is that we're talking about two different diseases. We have resectable and we have advanced. We know in patients with unresectable colorectal liver metastasis, they do the addition of cetuximab or borderline resectable works, and we'll provide some data on it. But I think Northern J and other people, they're just not realizing that a single metastasis is different than multiple metastases, and that's why I believe the difference in the outcomes, and why the EPIC trial, I think the data is reasonable and genuine. Again, they're different disease. Patients with single metastasis different than patients with multiple bilobar metastasis, different than patients with clearly unresectable disease. So in patients with resectable colorectal liver metastasis, the use of chemotherapy is controversial, and the best regimen based on the OHC trial is FOLFOX. We can use K-box since capecitabine is exchangeable with 5-FU. And for FOLFIRI, we just liver surgeons don't like irinotecan induced liver injury. So we try to avoid it as a first-line regimen if possible. In terms of targeted therapy in resectable colorectal liver metastasis, it is very controversial. Basically, there is no strong evidence to support its use. It is safe to add bevacizumab based on phase 2 feasibility trial. No strong evidence to support its use. And use of anti-EGFR in resectable, it's controversial, and data so far it's not mature enough. This is an example of a case at King Hussein Cancer Center we did recently. He is a 36-year-old male patient, locally advanced rectal tumor, had an LAR after neoadjuvant chemoradiotherapy back in February 2013, then received his adjuvant chemotherapy. 18 months later, he had slight increase in CA level, and a CT scan showed single liver lesion that's proved on PET scan with no extrahepatic disease. Since it's single liver lesion, good disease-free interval, so basically good disease biology, we decided to proceed as a GI-MDC for surgical resection. This is his, this was for intraoperative ultrasound here, but this is his wedge resection, and this is the margin-free resection of the single lesion. And this is his 5-month post-op CT scan. This is post-operative changes that will resolve with time. So let's jump to the borderline resectable colorectal liver metastasis. And the question is, can we really clearly define what's borderline resectable? As I showed you early on, there's significant lack of agreement in defining resectable colorectal liver metastasis. I think for borderline resectable, the definition is even more gray and more controversial among surgeons. It depends on a lot of factors, a lot of surgeon experience, presence of ancillary staff, presence of good supportive support at the same institutions. So in borderline resectable, what I'm going to use for the definition in general, and this definition is being more utilized in selecting this group of patients, is those with liver-only disease that is not considered amenable for upfront R0 resection due to inadequate future liver remnant, due to a proximity to major vessels for the remnant liver. So in general, this is the term that most people are used nowadays in the literature trying to select borderline resectable patients. And once we define this patient as borderline resectable, basically the term conversion or downsizing chemotherapy is used in the literature. These are principles of conversion chemotherapy. It is an evolving, dynamic area of the literature. There's a lot of talk about it. But according to the NCCN guidelines, these are principles have to be followed carefully when you utilize this strategy, which is the conversion. All cases should be discussed in a multidisciplinary fashion. It's only, again, liver-only disease that's not considered for upfront resection. The goal is the best response. It's not the maximal response. So once you have achieved your goal in terms of decreasing in size or the proximity to the vessels, you have to proceed with surgery. Surgical evaluation should be done every 2 months. Some people will do it every 6 weeks even. And then it should be operated as soon as he or she become resectable. Again, watch for chemotherapy-induced liver injury. And this is very controversial issue, which state that resection should be based on the pre-chemotherapy CT scan. Even if you have a disappearing liver metastasis, you still have to go and try to find, at least do a resection based on the pre-chemotherapy CT scan. Again, it is the multidisciplinary management what really matters in this group of patients. So let's talk about this strategy and what's the evidence out there and what's the best regimen. This is in 2004 in the pre-targeted therapy era. They used FOLFIRI in patients with unresectable colorectal liver metastasis. They had an overall response rate of up to 50% and an R0 resection rate of 32%. This is using FOLFIRI. This is using FOLFOX, again, unresectable group of patients. An overall response rate slightly higher compared to FOLFIRI. Again, small phase 2 trials. Really, we don't have a level 1 evidence so far, but 60% response rate, 40% R1, R0 resection rate with an R0 resection rate similar to FOLFIRI. So if we add targeted therapy in this subgroup of patients, can we improve the response rate and can this result in a better R0 resection rate? This is addition of bevacizumab to K-box in patients with unresectable colorectal liver metastasis. Again, 45 number of patients, only 45. The overall response rate was as high as 80% or 78%. And basically, the R0 resection rate was up to 40%. So basically, addition of bevacizumab to K-box results in a higher, slightly higher resection rate, but a very high response rate. Conversion to resectability now is being recognized as really an endpoint in some of these trials in patients with unresectable liver-only disease. And this is very new. This is brand new, where we use conversion to resectability as an endpoint. We're not talking about 5-year survival. Unfortunately, most of the trials, the phase 3 trials in patients with metastatic disease looked at survival as an endpoint. Now we're talking about conversion to resectability because we know once you convert these patients, you can achieve 5-year and even 10-year survival. This study published last week in Annals of Oncology, where they used bevacizumab FOLFOX versus bevacizumab FOLFIRI. And this regimen has been now more used in young patients where you're really looking for the best response. 80 patients, 40 in each group, and clearly unresectable group of patients at 16 institutions. Again, the primary endpoint is resection rate, R0, R1, R2, and then secondary endpoint is survival. This is what they found. Again, this is published online last week. The overall response rate basically was 81% in the bevacizumab FOLFIRI compared to 62%, and this was significant. And in terms of the R0 resection rate was as high as 49% in the bevacizumab FOLFIRI compared to 23% in the bevacizumab FOLFOX. So the addition of triplet chemotherapy to targeted agents results in a very high response rate and a significantly higher R0 resection rate in a clearly unresectable group of patients, or at least borderline resectable group of patients with liver-only disease. This comes with the cost of a slightly higher grade 3 toxicity of the bevacizumab FOLFOXIRI compared to the bevacizumab FOLFOX. Another trial using anti-EGFR in patients with unresectable colorectal liver metastasis. This is a study from China published last year. And you see here the response rate, the partial response was significantly higher compared in the chemotherapy plus cetuximab compared to the chemotherapy group, and also the R0 resection rate, again, unresectable group of patients, 28% compared to 13%. So in patients with borderline resectable colorectal liver metastasis, again, liver-only disease, no extrahepatic disease, in small phase 2 trials, standard chemotherapy results in 40 to 60% and R0 resection rate of 30%. This is the standard chemotherapy. Addition of anti-targeted therapy results in a much higher response rate and slightly higher resection rate. In terms of anti-EGFR, the data is maturing and it's not consistent, but again, it can result in a high response rate and higher resection rate. When chemotherapy is used before liver resection, it has to be done on protocols, and this is what we use at King Hussein Cancer Center in general. If we are going to do FOLFOX for FOLFIRI plus BIV, we give it for the first 4 cycles with BIV and the last 2 cycles without targeted therapy. We like at least 6 weeks between the interval between the last bevacizumab dose and surgery, and then we pursue surgery usually within 6 to 8 weeks after the last bevacizumab dose or 4 weeks after the last chemotherapy dose. This is an example of patient that presented to us, had synchronous sigmoid with colorectal liver metastasis, had sigmoidectomy outside King Hussein Cancer Center. They already treated him with FOLFOX with disease progression based on the outside institution protocol. You'll see we have 1, 2, we have this lesion on the caudate lobe on the IBC right here, 3, 4, 5, 6. So we defined it as borderline resectable based on size, number, as well as vicinity to the cava right there. And we gave him FOLFIRI with excellent response of all the disease that he had. Unfortunately, his future liver remnant, as you can see, his segment 2 and 3 and left lobe was small. So we measured his future liver was 26%, and we performed right portal vein embolization for this patient, and his future liver remnant went up to 34%. So we proceeded with the wedge caudate resection. This is the IVC. This is the wedge caudate resection, and also a right hepatectomy. He had 60% viable tumor, and he received 6 more cycles of FOLFIRI, and this is his CT scan 18 months follow-up. Normal CA level, this is the area of caudate wedge resection and adequate future liver remnant, and he's doing very well. Another case of 59-year-old female with synchronous sigmoid and liver mets, had sigmoidectomy again outside King Hussein Cancer Center. You'll see 1, 2, 3, 4. Again, this is the lesion on the caudate lobe, on the IVC. Multiple lesions, bilobar. This is lesions in the left. We defined it as borderline resectable FOLFOX BEV, and excellent response with excellent improvement in her performance status. So we proceeded with multiple wedge resections since most of her lesions were peripheral, as well as left lateral segmentectomy. And basically, this is her 4 months post-op CT scan. You see this is the site of her wedge resection. This is the site of the left lateral segmentectomy. All these are post-operative changes, and she's doing very well. Now, in terms of patients with unresectable colorectal liver metastasis, the term palliative chemotherapy typically used, but the question is, can the inoperable become operable? And what is the first best line regimen for this patient for these unresectable colorectal liver metastases? I think the interest of converting this group of patients came from the René Adam group from France, where they found that 14% of initially clearly unresectable patients eventually underwent resection after chemotherapy. This was just retrospective analysis of their data. And this 14% of patients achieved a 5-year survival of 33% and a 10-year survival of 27%. From this part of the literature, people start talking and try aiming for patients with initially unresectable colorectal liver metastasis. Can we aim for cure? This is a study published 2 years ago. They looked at 10 observational studies with the term in patients with unresectable colorectal liver metastasis. they found a very high response rate, and up to 22.5% of this patient eventually underwent R0 resection with almost a median survival of 5 years. But the problem, if you're going to look at the literature in this clearly unresectable group of patients, you'll find very large number of prospective randomized controlled trials, phase 3 trials with level 1 evidence. But none of them had selected the group of patients that we're trying to identify, which is liver-only disease. And none of them had looked at conversion to resectability as an endpoint. And none of them had requested surgical consultation before entry into these trials. And most data on secondary resection was retrospective. This is a summary of a lot of these phase 3 trials. You'll see a very high, different regimens, no targeted therapy, with targeted therapy. But you'll see the response rate definitely higher with the use of targeted therapy, as well as the resection rate is very high. The only exception is the Fluro study here, where they have a decent high resection rate, but a very high R0, R1 plus RFA resection rate. The question in mind that I always had, does response rate in patients, in this group of patients, correlate with secondary resection rate? And is it really justified to aim for the best, for the regimen with the best response rate? And this is a very nice group of authors that they did this correlation between response and resection rate. This is in 2005, before the era of targeted therapy, and that's held true for patients with liver-only disease. So liver-only disease, higher response rate results in a higher resection rate. In patients that are unselected group of patients in phase 3 trials, basically the correlation is less significant. Same group of authors had updated their correlation curve in 2013 by adding the trials that had added anti-targeted therapy. You'll see, with the only exception for Fluro that we talked about, that has very high R0, R1, RFA resection rate. Most resection rate after 60% response rate just clustered in the same area of the curve, between 20 to 40%. So after 60%, with the addition of targeted therapy, what we're looking for is a secondary resection rate between 20 to 40%, according to this trial. So does response rate correlate with secondary resection rate? I think yes, in patients with borderline unresectable liver-only disease. I think this is very important. Patients with extrahepatic disease, widespread disease, I think it's not correlating. So in conclusion, can the inoperable become operable? The answer is yes. And the question were, especially in patients with stage 4 colorectal cancer and unresectable liver-only disease, please think conversion. And what is the best regimen? I would say any regimen with a response rate above 60%, but typically the resection rate did not change much after that. So again, principles of conversion therapy. Cases should be discussed in the MDC fashion. Liver-only disease that's not considered for upfront resection. The goal is to obtain the best response, not the maximal response. Evaluation every 2 months. Should be operated as soon as she become resectable. And the section based on the pre-chemotherapy CT scan, and watch for chemotherapy-induced liver injury. This is my first liver resection at King Hussein Cancer Center. He's a 50-year-old male, excellent performance status. He had a right nephrectomy for right renal cell carcinoma in 2007. He had right colon cancer and synchronous liver metastasis in September 2009. He had a right hemicolectomy, and on exploration, patient was found to have bilobar liver disease at that time. He given chemotherapy FOLFOX, progressed on first-line chemotherapy after 6 cycles, then switched to FOLFIRI-BEV. He had 2 years of FOLFIRI-BEV with excellent response. And he presented to my evaluation in October 2012. According to the studies that we performed, he had only disease visible in right lobe of the liver. There were no disease. I think the left lobe just had disappeared based on chemotherapy. And also he had a single lung lesion in the right lower lobe. So in summary, 54-year-old, excellent performance status, excellent response to chemotherapy. He has what we define as a resectable disease, but he had an extensive chemotherapy with end organ damage. His platelet was around 69 and total bilirubin 2.3. We took him to surgery, giving him the best chance. We spent 5 hours doing lysis of adhesion because of his right nephrectomy and right hemicolectomy. What we identified is mainly lesions in segment 6 and 7, which is the right posterior sector, and only had small lesion in the segment 8 of the liver. So we did a right posterior sectionectomy and local excision for this lesion, and his final pathology showed the right posterior sector, multiple liver lesions, completely excised, and the segment 8 lesion was just bile duct hematoma. 3 months later, he had VATS wedge resection of his lung lesion, and pathology was metastatic renal cell carcinoma. Patient was kept on follow-up, and 22 months later, his disease is free and he's enjoying his life. It is the multidisciplinary management. We as a team work together to select the best group of patients to provide them the best care. This is a very nice say from Black Caddy. He's a famous, aggressive surgical oncologist at Harvard. He said it's all about biology. And he clearly says biology is a king, selection is a queen, technical maneuvers, surgery, chemotherapy, portal vein embolization, whatever, are prince and princess. Occasionally the prince and princess try to overthrow the powerful forces of the king and the queen, sometimes with temporary apparent victories, usually to no long-term avail. This is quickly describe our experience here at King Hussein Cancer Center. I joined KHC in October 2012. My first liver resection, which I talked about, was in December 5, 2012. So far, we performed a total of 54 cases. We did first laparoscopic liver resection in February 2013. We had a great group of people that works with us and helps us in this effort. We have a great ancillary support, CT scans, MRIs, and also software for volumetric analysis. Dr. Munder Qindil helps us with this volumetric analysis. And we were able to use this energy device. We are the only one in the Middle East that used this state-of-the-art device for liver resection. And we recently included our T-probe for intraoperative ultrasound. Total, again, of 54 cases. Majority of them were for colorectal liver metastasis, cholangiocarcinoma, 1 for hepatoblastoma, 1 for HCC, and non-colorectal liver metastasis in 4 patients. Again, this is the summary of the patients. Right hepatectomy, 12 patients. Right hepatectomy with extrahepatic bile duct resection 2. Right hepatectomy with caudate resection 1. Left hepatectomy 2. Again, this is the description of the studies. We did liver-only resection in 32 patients, synchronous resection with colonic procedure in 11. Most of my complications happen in this group of patients where I did simultaneous colonic resection, and some other in-block resection with diaphragm, gastrectomies, duodenum, and right nephrectomy in this group of patients. This is the estimated blood loss, the mean around ABL around 500, time around 5 hours, 5.5 hours. Hospital stay around 9 days, and age around 51. This is again ABL. The mean is around 500. Hospital stay 9 days, including the day before surgery, and operative time around 5 hours, 5.5 hours. We have some, again, outliers for every one of them. We had 1 mortality in patients with cholangiocarcinoma and a morbidity of around 24%, mainly wound infection, bile leak, pneumonia, prehepatic abscess, and post-op renal failure. This patient sustained an IVC injury, but we were able to repair it, and he's currently doing well with normal kidney function. This is the survival for the first 25 cases done in the first year. 21 of them are alive. 14 had recurrence. 14 alive and without recurrence. 11 had recurrence. 2 liver only, 1 resected, and 1 was unresectable. 3 liver and extrahepatic, 2 were resected, both lung and extrahepatic disease, and 6 were extrahepatic. This is some interesting cases. I will just, this is an example of 2-stage hepatectomy. Patient presented with bilobar liver disease and synchronous presentation. You'll see a very large disease here adjacent to the IVC, and bilobar liver disease. We give him full FOXBEV. Excellent response. We decided to go for 2-stage because of his relatively small future liver remnant and synchronous disease. And he had multiple wedge resection on the left, ligation of the right portal vein, and sigmoid colectomy. This is the right portal vein being ligated. This is the left portal vein. This is the main portal vein. And this is the wedges on the left. This is on the falciform ligament, and this is the left portal vein was just in the base of our resection, and that was very critically to preserve. Then we also did the sigmoid colectomy at the first stage, and then he made it, he had significant improvement in his future liver remnant, and then we performed the right hepatectomy for him. This is his IVC, and this is the transection service. And this is his CT scan 12 months follow-up. This is an example of patient with disappearing liver metastasis. You'll see a very large lesion on the caudate lobe on the IVC that had disappeared. You can barely see it. Actually, it was missed on CT scan and MRI as a disappearing liver met, but we stuck to our principles where surgery should be based on a preoperative chemotherapy. This is the caudate lobe resection. You see the IVC here. This is the left hepatic vein. This is the right hepatic vein from the other side. And this is the other wedge resection. And you see this is, again, the caudate lobe resection, and this is where the IVC stands, and these are the lesion, less than 5 millimeter, and actually was completely replaced by fibrosis with no viable tumor. And this is her CT scan 4 months later. We also utilized some group of patients, what's called the liver first approach. Again, 33 young female, multiple bilobar colorectal liver metastasis, Xelox Bev. Her primary was symptomatic, so we inserted a stent to give her the benefits of the chemotherapy. Excellent response, and basically multiple wedge resection, left lateral segmentectomy, and 60% viable tumor. Then we proceeded with 1 month later, laparoscopic left hemicolectomy, and she's doing very well. This is 4 months post-op, and she's doing well. Finally, I would provide you with some updates on the Stop CLAPSY project. As you all remember, this is how central line were inserted before the project, small slit sheath, not completely covered patients. These are the way, this is the way that things were done. This is the trash, and this are the instruments that going back and forth with the inserters. There were no chlorhexidine. This was the insertion tray at that time, and there were no use of Fluro machine drape. With your help, we went into this bundle for improving our strategy, which is we worked in a lot of education for people who insert and maintain catheters. We clearly defined the maximal barrier precaution as a must, chlorhexidine for skin preparation as a must, an ultrasound for CVC insertion, again, as a must. And then we provided a checklist to follow up on these things, and then prompt removal of the CVC when it's not needed. We provided initially a KHC-made kit, and this is how insertion was done. After that, you see this is the ultrasound, and this complete maximal barrier precautions were utilized very, very effectively. Again, ultrasound guidance and maximal barrier precautions. Just 2 months ago, we were able to provide the prepackaged complete sterile kit, maximal barrier precautions, and now it's being used. This is a nice drape where we provide all the anatomical landmarks, and again, maximal barrier precautions. And in terms of the data, this is where back in Q3 2012, where we started talking about the project, and this is our results now. We went to as low as 5.6, they went high 7.3, and then 5.5, 5.7. This is Q2, quarter 2 2014, 4.4, and then Q3 2014, 5.2. So we have done good so far, but I would encourage everybody of you to keep helping us in this project, to stick to the rules, to stick to the checklist, and to stick to the maximal barrier precautions. This is our goal, is to really identify, to go as low as possible. Want to thank the great team that's working with us on this in this project, especially Sausan with her team. And thank you very much. مش موجود الباثولوجيست؟ حقك علي بحطه مرة ثانية. نيوكليير حطيته، لا موجود. هسه برجيك. ايش هو؟ others? Now, pathologist definitely has a role, and actually I'm preparing a lecture on really in patients with resected post-chemotherapy, the changes, the descriptions. It's very interesting, but definitely has significant role. But I definitely والله حقك علي انا اسف. لا هاي التيم تبع الهيباتولوجيست. هاي نيوكلير ميديسن تحت يا خلاص ولا يهمك المره الجايه نحط باثولوجيست.
Regarding any resection, we always face the problem of surgeons بشكل عام بيكونوا متحمسين كتير, so they open through the tumor, and at that time it becomes very difficult for us pathologists to be 100% sure about the resection margins and the absence of contamination because of the opening the specimen not in the pathology lab. So we always encourage people, surgeons. I know مرات كتير واحد بيكون كتير متحمس, بس it's very helpful إذا السبيسمن بتضلها مثل ما هي and then it's opened بالpathology أو وقت ما بدكم إذا حابين جدا تشوفوها you come down to the pathology lab and we open it together. It becomes sometimes extremely difficult to assess the resection margin إذا كان في any sloughing from the tumor into the resections. Thank you.
يعني I can discuss with this issue with you in more personally. I had issues, to be honest with you, with the pathology department when I sent the fresh specimen them and asked them about the gross margin. This is what I care about before the specimen in formalin. This is what I care myself as a surgeon. I need just a negative margin. And for some reason, I did not have a lot of help initially. So I tend to do what we did at the fellowship, to be honest with you, is to open and check the margin ourselves. And I can tell you most liver surgeons, this is what they do. This is what they believe in the margin that they see in the OR when they cut the specimen, and they're happy about it. If it is closed, we'll send it for frozen. And I also send either, and I go myself or my fellow go down and tell them exactly what to check. When I had, one day I sent, for example, five specimens for checking margins, gross margins, and I had a lot of back fights from somebody. It's too much. But anyway, so what I believe myself, this is the margin that I'm looking for. If I am worried, I will send the fellow or myself go down there and tell you I need to check this for frozen. And that's what I've been using, and I'm very happy about it. Especially sometimes some of this resection goes beyond working hours, and we just have to be sure that this is a negative margin.
And just talking about in general, you know what perhaps you know more than most other people, we usually ink the margin.
Sure.
We leave it to rest for some time, and then we resect it. And under the microscope, we're pretty sure how far is the margin.
But that's after formalin, and then formalin shrink everything. And what I really believe is this is again the margin that I'm looking for, as you can see here. This is fresh specimen. This is at least a 5 millimeter, 5 millimeter, 5 millimeter, completely resected. If I perforate the tumor intra-op during resection, again, the idea is to do an in-block resection. If at some point I believe I perforate the tumor, this is just really bad. I just, you can't do it. But I tend to do more further resection in that case. And I had just a case recently where I know I cut through the tumor because I had bleeding. But then I went ahead and I took another en-bloc resection.
What's the role of radiofrequency ablation?
It's a topic of a full lecture, but in general, if you can resect, it's better. This is really standard in the literature. You can add it as an adjunct. For example, I did not mention on the case that I show. You tend to do parenchymal sparing techniques in general if you can. So centrally located lesions where you have to do an extended resection, typically you tend to ablate if possible to achieve a complete ablation. But in general, if you can resect, then resection is better than ablation. Another question? Well, thank you very much. Thanks, and Happy New Year.